With that, I'm pleased and excited to have Dr. David Friscia with us once again. He is one of my favorite speakers because many of the things he's talking with us about today are things I myself personally deal with my feet. And so I always learn new things, and I'm, needless to say, very excited to have him here with us. So with that in mind, I'm going to turn it over to Dr. Friscia. He will tell you about himself and what we're going to be talking about. Doctor, it's all yours, sir.
Thank you. Thank you for having me, and thank you all for taking your time out this afternoon to listen to what I think is a very interesting topic. First, a little bit about me. I've been at Eisenhower over 30 years now, believe it or not, and I've been doing foot and ankle surgery a long time. And this is one of the things about this topic is that's exciting, is that I've been doing this a long time, and this is really a procedure and innovation that's developed over the years and makes a lot of sense. And I'll go into that more a little bit later. As for, again, I've been here over 32 years. I'm a fellowship trained orthopedic foot and ankle surgeon. And I, enjoy doing surgery and also treating people conservatively. The majority of our patients, actually, we treat non-operatively. Not everybody needs surgery, but if someone needs surgery, there's new and innovative ways to do it. And as you know, I've been at Desert Orthopedic Center my entire career here. As you know, we're a group of over 16 orthopedic surgeons and pain management doctors who treat all areas of the body. And again, I concentrate on foot and ankle, and I do some teaching at UC Riverside for the students, and thoroughly enjoy it. But this topic, bunions are one of the most common foot and ankle problems, and you've all heard of bunions, and I'm sure you've heard horror stories of bunion surgery from friends or patients or friends or relatives who had a bunion or had bunion surgery, and you hear different things, and it's just a very common problem, and can be very painful and debilitating. And fortunately, I think we've really learned a lot over the years, and I like this procedure that I'm doing. Is I really didn't expect I'd be doing a lot of bunions at this time in my career, because I like ankle surgery and ankle replacements and complex things, and bunions were kind of not the well, part of it was that the results years ago, bunions were not as reliable, but now that they are, and we can correct big deformities and help people, I think it's become very exciting. So I'll start with a little background of the procedure. This procedure that I'm talking about is interesting because, like a lot of things, we keep learning more and discovering, and the so-called Lapidus procedure to correct a bunion was described many years ago, and it was because there was a doctor named Lapidus that felt the bunion was from increased mobility of the first ray, the bone in the foot, the base of the metatarsal. It wasn't that you had a bump on the side of the foot that was growing. It was that your foot had some instability. The foot an ankle have 28 bones and joints, so it's very complex. There's a lot of things moving, and ligaments and joints, and a lot of little joints that don't move much, but if they become unstable, you can develop a flat foot, a whole nother issue, or you can develop a bunion. So anyway, there was kind of differing schools of thought. Some people felt, okay, well, we don't need to correct that part of it. We just need to correct the bump in some way by cutting the bone or straightening the bone or doing something. That's why there's over 100 different bunion procedures described, and and that's an indication that there was no one procedure in the past that really worked reliably. And it was interesting, in my training when I did my fellowship in foot and ankle surgery at the Mayo Clinic in Scottsdale with one of the leaders in foot and ankle surgery at that time, and he kind of and we could demonstrate that if we wrap the foot with an ACE wrap, that a patient had a large bunion, you could wrap the foot, and tightly bind the foot, and you could actually correct the bunion in a lot of patients, showing that a lot of it was from first, from intermetatarsal, from instability of the foot, from not just a bump that was growing. So I kind of relate to that background years ago. This is just an example of wrapping it where you kind of, that in itself provided some correction, showing it's not just the bump, a rigid bump, it was actually instability. And this is just an example where of an X-ray showing that, with just wrapping, you could get some correction of a bunion. Hallux valgus just means the big toe is crooked. That it's not straight following the first metatarsal bone. And this is actually, it's interesting. Years ago, I did a procedure that was not quite this procedure, and it kind of made sense in a lot of ways, but rather than these are fairly moderate bunions, and you can see the bumps here, and rather than cutting the bone and making the straight bone crooked, we did is release some of the soft tissues here, and then here just corrected it manually, and then put what was then an absorbable type screw between the first and second metatarsal. So I put a screw between these two, and you actually got pretty good correction. You weren't doing a formal fusion, so I wasn't, I think that procedure worked pretty well for a lot of patients, although, some patients had a recurrence if once that screw absorbed or broke, and it wasn't as reliable as I might have liked, but it did work well, and I think it really is the same concept that I'll go into. And so the traditional receipt, the teaching when I trained was actually what was called a distal soft tissue procedure with proximal osteotomy, which just was the typical procedure where you would cut the bone and make a straight bone crooked, and try to correct the bunion. And initially it looks okay, but there were a lot of potential complications with that. And that's, part of the reason bunions kind of, you hear horror stories. A lot of people, I'm sure you've had people tell you, never get bunion surgery, it's horrible. And there's and in this procedure, there's a risk of malposition of the first metatarsal. There's a risk of having pressure under other parts of the foot. There's a risk of overcorrecting it, that having the toe, rather than going in valgus to the left, suddenly it goes to the right and is crooked the other way. And and then there's other procedures that were described, cutting the bone at the base and at the end to correct it. So bunions, as I've got to emphasize, in the past there was a higher a rate of recurrence which is higher than we would like, even with the current procedures. And because of that, obviously, you led the patient to satisfaction. You're not happy if your bunion comes back. You have to go through another surgery, or it doesn't work and you have pain again. And I think the realization that we've come to recently, and this the procedure I'll be describing is emphasizes that bunions are not just a two-dimensional problem. It's really a three-dimensional problem, where it's not just that the bones are moving over but it's actually moving over and rotating. So it's really an instability problem and a rotational problem. And I think we've really come to, with the research and what we've done, we've really realized this, and I think we've come to a reliable, reproducible procedure. And the key is that, again, you can't just straighten the metatarsal, you have to rotate it also, and that's a key of the procedure I'll be describing. And so that's why the talk today is on this new Lapidus type 3D reconstructive foot surgery. And again, this fusion, this basic surgery was described, in I believe it was 1920, but the problems were we didn't have the instrumentation for it, and it wasn't as reliable as it is now with the proper instrumentation and teaching and guides. And as I've said, the multiple studies show a high recurrence and complication rate with a lot of the other bunion procedures. Some procedures have had as high as 78% recurrence rate. That's huge. Some are 20%, but still, that's pretty large. Um, the again, the recurrence rate and the degree of correction was just not sufficient in many of the older procedures. And you can see some of these x-rays showing where, you've cut the bone in various ways and fixed it with screws, but you're not correcting the source of the problem is at the base of the metatarsal. I think if you can see my arrow here going around here, the instability is here, it's not here, and you're correcting it here. And that's kind of the error, I think, that in the past that was being made. And I think over the years we've come to understand the true pathophysiology of this problem. Like I said, no matter where the metatarsal's cut, you're not restoring the normal anatomy. You're creating a new deformity. So this slide kind of shows a normal metatarsal foot, normal metatarsal bone in the foot. That the metatarsal bone is here, the toe's here, and the toe lines up with the metatarsal. These little dots here, which when sometimes the patients come in and see that on the x-ray, they're wondering, what are these little spots here? And that's a normal thing. That's one of your sesamoid bones. That's two little bones that are they're not floating there. They're actually part of the flexor tendon that gives you strength to push off and helps to, and increases the lever arm. So these are important little bones, and these are made to line up under the metatarsal. If they don't line up under the metatarsal, they're not doing their job. So anyway, this is what a normal foot looks like when you correct it. So this was a bunion, and in this case, it was corrected by cutting the bone in the middle of the bone. There's these dots here are screws. I know it's a little hard to see. And you can see now the sesamoid bones are not lined up. You haven't restored the normal anatomy. And this is an example of a slide of what you may have heard said, sometimes advertised and publicized. Some doctors do so-called minimal incision surgery. Through a smaller incision, you make a small incision and shift it over and put some screws in. You can see this distorts the normal anatomy grossly. The bone used to go this way, and now you have half the bone over here barely hanging on by these two screws. And that looks good initially, but there's a complication rate and a recurrence rate, and it's not normal anatomy, and this joint is still very unstable. So like I said, bunions are, it's more than a bump. The misconception is that an overgrowth of bone that can be shaved off. Yeah, just get rid of that bump. But that's not the problem. It's the instability of this joint. And like I said, it's the instability of this joint that there's a lot of, obviously all your weight's going through your foot every day. I mean, it's a lot of pressure, a lot of forces, and you have 28 bone joints, and all these little joints have ligaments, strong ligaments, and they're stability joints. There's not a lot of motion goes through here. Most of your motion goes through the big toe joint, which is what you want to maintain and keep aligned, because if it's out of alignment, you have increased risk of arthritis and pain and spurs and things like that later. So this is just kind of showing that it's how it's a rotational deformity, that you can put a pin in a patient with a bunion. You can put a pin in it in surgery and show that if you rotate it, you actually can bring it over and correct it without cutting the bone. With just a rotational force, you can correct it. You just have to maintain that alignment. And these slides show that normally these are the dots signify the sesamoid bones that are in the flexor tendons, and that with a bunion, with the rotation, the sesamoids start moving off, and all the muscles and tendons insert on the toe, and that gets worse and worse over the years. That's why bunions get worse. And again, this is another slide showing the normal anatomy with the normal alignment of the big toe. And then this is with a little rotation, you see the sesamoid bones moving off, and a bunion, a mild bunion. And here you have a more significant bunion with the sesamoids moved off. Now these are not just moved, in one plane. These are rotated to the side, and like it shows here. And there's, and as the joint becomes off, just like a tire that's wearing on the side, the joint wears down. There's an increased chance of arthritis and pain and problems later. Um, and like I said, they all bunions have some level of deformity and instability here, and with that rotation, that's causing the deformity. It's not the bump growing. This can be the same exact foot, but just with rotation, that becomes more prominent as it rotates out because of instability at the base, at the middle of the foot. And 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 sometimes, it's been gratifying too in this procedure. If you stabilize this joint, a lot of patients feel better because you've stabilized a joint that's, the arch of the foot that is starting to give them some problems, and correcting the source of the deformity. And as you've seen already, but the bunions on X-ray, this is a normal foot with a big toe lining up with the metatarsal bone. And here's a bunion. And you know what a bunion looks like when you see it. You see that bump. But again, the bump is caused by the metatarsal rotating and deviating and putting pressure on the skin. And you're seeing a bump here. And you're seeing a bump on the inner part that as the toe is pulled to the side by all the muscles and tendons that insert there. So this is just a kind of a comparison to the Leaning Tower of Pisa, which I think that some people like say it's analogous to. It's that you have an unstable foundation, so it leans sideways, and then that kind of leads to the bunion. And as it leans, the bone sometimes elevates up. So it's leaning, it's rotating, and your big toe should take at least half of your weight and force. It takes the pressure. That's why it's the big toe. But if it starts elevating up, then it's not doing the job. So that puts pressure on the other bones in your foot, and that's why sometimes, frequently with bunions, you get associated what's called metatarsalgia, pressure on the bottom of the foot. You get calluses, you get hammer toes, you get, sometimes the second toe develops a hammer toe that crosses over the big toe. And again, the pain in the forefoot can be significant. So in the past, traditional two-dimensional bunion surgery, involved just doing something distally or at the end of the bone. So, you still have the instability here, and you straighten the bone at the end. And so what you've done is you cut the bone, shifted it over, fixed it in some way, and you made what it was a straight bone crooked. But, cosmetically, that looks okay initially. But the problem is, and for a lot of people that may last, but in some people, you still have the source of the problem here, and this can continue moving, and you could develop a recurrence. And as I said, like this shows the bump's gone. You've cut it here, but the joint's still unstable at the base, and it can lead to a recurrence. So, this is an example of significant bilateral bunions on X-ray. And this is an example of an X-ray showing the 3D bunion correction with a Lapidus type procedure. And the key is that you're stabilizing the base, you're stabilizing the foundation, and you're fusing this joint. Now, I think initially we were hesitant about fusing a joint that, maybe, we typically fuse or arthrodesis joints that are arthritic joints, and that gets rid of the pain. But this isn't an arthritic joint, so usually, but it's an unstable joint. And the key is that we don't want to fuse a normal joint, but it's not a normal joint. It's an unstable joint, and the beauty of it is that it's a joint that doesn't move much. So because it doesn't move much, you don't lose any real motion from fusing that joint. You just stabilize the foundation, and you're maintaining the motion of the big toe joint, hopefully preventing future arthritis and problems, and maintaining the big toe joint, which is, has the most motion and is the most important joint of the forefoot. So that's the beauty of the procedure. It really does address the problem and salvages corrects the bunion, and hopefully, it prevents further problems of your big toe joint, gets rid of the bunion, and you won't develop as a problem with hammer toes and things like that as commonly. So so for this procedure, the first cuneiform metatarsal arthrodesis, which is the 3D bunion correction, it's a procedure where we align realign the bones. And the key is that we really came up with a reliable instrumentation to make the procedure simpler to do, reproducible, and effective. So again, this is just a picture of showing a device we use during the procedure to rotate and straighten the bone. And then these plates are, once you prepare and cut the joints, these plates hold the bone until your body heals it, which, takes 6 or 8 weeks to fuse it. And then once it's fused, it's stable and fused forever. And again, an example of this is a moderate bunion. This is the bump here, and then this is the 3D lapidus type bunion correction with these 2 titanium plates at the base that your devices have helped cut this appropriately for the alignment, and now it's straight. The sesamoids are where they belong. The foot's stable, and again, I think it's been a very reliable, reproducible procedure. To emphasize it again, there's you can, in the past we didn't have good ways to do the procedure. We would say, well, we need to correct this joint, so we'd make some cuts and remove the joint and then try to eyeball it and then push the joint together and fuse it. And the problem with that is that not having the instrumentation, it wasn't quite as reliable. We'd take away more bone and there'd be shortening. And if you shorten the first metatarsal, then you could put increased pressure on the other parts of the foot, and that would lead to other problems. So that's why the lapidus procedure did not catch on years ago. That's why we, I think over the last few years with reliable instrumentation, it's really become effective, and I think the gold standard for bunion correction. And so as it shows, you correct the deformity before you cut. So you have these devices that you put on to hold the deformity. And then this is a little gold cutting guide, just like, we use cutting guides with a knee replacement, with ankle replacement, with other surgeries, so this is a guide that under x-ray, we put this on, and then we check it under x-ray during the procedure, and then cut before we fuse and make sure we've done the correction. So we have it corrected and then make the proper cuts. So that's kind of the beauty of the instrumentation and why this procedure, I think, has taken off in recent years. And again, just a slide showing the correction. This is a bunion, and then after correction, you can see how it well lines up with the toe. These are, if you can see that, this is before surgery. You can see this is rotated. The sesamoid bones are kind of like a tire wearing on the side. These sesamoids are rotated inward. They're not doing their full weight bearing. This one's taking more weight, so you might have pain over it. This one's taking less weight, and that gives you pain. And you can see here now it's balanced, and these are, tracking where they're supposed to. And then this is a X-ray during surgery showing how we visualize it, that we have this device on that has corrected this was a bunion. With this device, it corrects the deformity and corrects the bunion. We haven't fused anything yet, and then we have this device on, and then we're able to put the cutting guide on and cut it properly to maintain the correction and the fusion. So the key to it, as this shows, is that you have the bunion, you correct it with the device, and then afterwards you put on this cutting device, and then with the cutting device, you make your saw cuts during surgery, and so this cuts the bone to line it properly, as you can see in this picture here, and then we have a compression device where you have pins in the bone and then push the bones together to hold them, and your bunion's corrected. Now, but we have to heal that in position. So now you have a temporary, where'd it go there? A temporary pin in that's holding it. And then we put in these plates and screws, these small titanium plates and screws that are very thin. You don't feel them. They're well under the skin. And these hold the bone, and your body, you've cut the bone and prepared it so that your body makes that one bone, and it's a stable single bone. And again, the procedure has high patient satisfaction, a low recurrence rate. And again, I actually just did a case today where a patient had her first surgery 6 months ago. She came in for the other side. Bunions are frequently bilateral, and I think the gratifying thing and satisfying thing and showing that it's a effective procedure is that most patients who have it on both sides do come back for the second side because they're happy with it, it's effective, and they really get a excellent correction. And again, I think I mentioned before, the hesitation, I think, when I first started was that why are you fusing a normal joint for a bunion? You approach the bunion's at the tip of the toe. And again, that's not the cause of the bunion. So you're sacrificing a abnormal joint. You're fusing what is a pathologic joint. It's not an arthritic joint, but it is pathologic because it's not stable. So you're stabilizing the tarsometatarsal joint here to preserve the functional joint, the first metatarsal phalangeal joint, here. So you can see, for instance, this patient. This was an example of a patient who had different bunion surgeries on each side. On the left side, she had a Lapidus type procedure, and to fuse that, and on the other side, she had a more distal procedure. Now, in this case, they cut the bone, and and actually had to cut the bone, the metatarsal bone, and cut the toe bone, and that. She hasn't had a recurrence, but you can see there's some narrowing of that joint, and she's developed some degenerative changes and arthritis of that joint over the years. And if you look at the alignment, the rotation was never corrected on the right foot. Well, the rotation was corrected on this foot, which may be the reason why this joint is wearing down with time. Both of them actually look okay. Fortunately, this side on the right looks okay. It hasn't recurred, but the joints degenerated over time. So the Lapidus 3D bunion correction, again, it's an outpatient surgery. Patients get the beauty of outpatient surgery nowadays is that with anesthesia, is very good at doing lower extremity blocks. So they're able to, before your sleep, put some numbing medication in your leg, and able to, numb the leg so that you don't have any pain for the first 12 to 24 hours. So as you know, you may remember or know that sometimes the worst pain is immediately after surgery, but that worst pain is now blocked for anywhere from 12 to 24 hours. And these blocks are now common for obviously lower extremity surgery. Obviously, people have total joints. That same thing's being done. Shoulder surgery is being done. And that's why the vast majority of orthopedic surgeries now are outpatient surgeries. You don't have to stay overnight for most procedures, depending on your health issues. But again, almost every, the majority of orthopedic surgeries, people are going home. Bunion surgery almost always going home unless there's some complicated health issue that requires you to be in the hospital, but that's very rare. So there's minimal pain for the first 12 to 24 hours because of the block. And then for this procedure, you're never in a cast. You're immediately in a soft dressing and partial weight bearing in a boot. And, some doctors have different protocols, but this is a very stable construct. So I let people partially weight bear in the boot for the first 2 weeks. And then after that, you can weight bear as tolerated, be full weight bearing in the boot for the next 4 to 6 weeks. So you're in a walking moon boot for, anywhere from 6 to 8 weeks. And then after 8 to 10 weeks, you can usually resume your full activities. And, bunions, any bunion surgery, I mean, again, you are cutting bone, you are doing a correction. There was advertisements years ago, people, about lunchtime bunionectomies and about, just making a little incision, shaving off something. But again, number one, that foot surgery, after any lower extremity surgery, you got to elevate it, you got to take it easy. It's not, you have to take a little time off. But this procedure, the healing is fairly quick, and people do well. And again, you're weight bearing fairly soon. You're full weight bearing 2 weeks after surgery, and never in a cast. So I think the recovery is easier than some of the other surgeries where, where especially in some of the where we're cutting the bone in other areas, those are more unstable, and you had to be non-weight bearing for longer periods of time or be in a cast. This is much simpler and reliable. And just looking at the x-rays, I mean, you look at the left side, this is an example of a bunion surgery with, sometimes called a minimal incision surgery, where they're making small incisions, making small cuts and moving things over. Initially, the foot might look okay from the outside. When you look at it, these bones are way off. It's kind of, at least from a radiologic standpoint, something doesn't look right. The bone it can heal in this position. It can look good for a while, but you haven't solved the problem yet. The beauty of this Lapidus 3D bunion correction is that, again, you're solving it. We've found the source of the problem. Like in medicine, we want to cure the problem. We want to solve the source of the problem, not paste over it. And so this cures the source of the problem, stabilizes the bone at the base, and cures the bunion. This can just be a Band-Aid over it. And again, I think the complication rate and recurrence rate is much higher with, I think, other types of procedures. And it's, again, with the 3D bunion correction, it's solid, reproducible, modern fixation. And as I've said, we're fixing the root cause of the problem. We're correcting the three-dimensional deformity, not just moving it over, not just taking the bump off, correcting the rotation. There's less time off work. There's no cast, and it really, the key is that it's really designed for permanent correction. And the studies have shown that the recurrence rate is extremely low, much lower than almost any other procedure. And the satisfaction rate has been very high with this technique. So anyway, that's a fairly quick summary of a big topic of bunions. And again, it's been an exciting area for me and interesting, because I think it's in my over 30 plus year career, I've really seen it evolve, and kind of it's been satisfying that we've finally come to an understanding and a procedure that is reliable and effective and can solve from anywhere from mild to moderate bunions. And again, I see a lot of severe bunions and severe deformities that we can really correct with this procedure. And again, it's not, bunions were thought to be more common in women, and in the past was more common perhaps because years ago women would wear more fashionable shoe wear, high heels, or things like that, and that can predispose you to it. But there's a lot of bunions are hereditary, and maybe the majority. And that if your mother had bunions, sometimes you have bunions, and you've seen your mother's feet get worse and worse, and but much of it's hereditary, and especially in men, it's hereditary. You can see a lot of men come in with severe bunions, and obviously they're wearing even wearing different shoes. You can accommodate that, but the men sometimes have more pain in the midfoot because of the instability. And I've and even younger people I've sometimes had to do this procedure on because they're having pain and an early deformity. So it's been a satisfying, interesting procedure that I think solves a lot of problems and is very effective. So anyway, I'm open to answer any questions or comments you may have about this topic or other finagle topics if you have it.
Great.
Thank you.
Thank you so much, Dr. Friscia. We don't have anything in the chat yet, but feel free to use the chat if you want to ask a question, or please feel free to unmute yourself and ask a question of the doctor directly. Just let's be cognizant of each other as we unmute. Feel free at this point to do that. All right, while I'm waiting on that, my question for you, doctor, is in regards to, I know within Desert Orthopedic, we have our pain management specialist. So can you talk a little bit about how you work when a patient comes in on an initial kind of evaluation? Do you work directly with pain? How does that process work where they coincide with you and the pain management?
Right. Well, for routine pain, I mean, obviously patients come in, if you're just addressing post-surgical pain, for this kind of procedure, obviously the patients have the block at the time of surgery, and then after surgery, you can take, we prescribe pain medications if you need it. Some people, everyone has different pain levels, and it's been interesting too for this procedure, which is not a trivial procedure. The pain levels less than I would have expected, and some patients are surprised that they don't have that much pain. But again, everybody perceives pain differently, and it's different. But some people can just take Tylenol or ibuprofen afterwards, Advil over the counter. But we also prescribe Percocet or Norco if necessary for the first few days. Most people do not need that much of the narcotic type medications, but you can certainly get it for a few days if you need it. The key to the pain relief after foot and ankle surgery especially is need to elevate it and take it easy. And that's the hardest thing for most people, is because it's, everything we do, you're walking and the foot's always the lowest part of your body, right? I mean, and it's really got to be above your heart for the first few days, because swelling causes, puts pressure on the soft tissues, the nerves, and increases pain. So the key is, elevation, keep the swelling down. You all know that with an injury, you have to keep the swelling down. Ice, elevation, things like that help. In terms of pain management, for routine surgery and problems, I mean, we treat, as orthopedists, we treat pain acutely. If you have come in with for instance, arthritis in the foot or the knee or wherever, we can do a cortisone injection. We can do something temporary to help that. We prescribe anti-inflammatories. Pain management is frequently more for the more complex problems or chronic pain, where if a patient has neuropathy or has a nerve injury from something, or a back problem that cannot be fixed surgically or things like that. So there are patients we refer to pain management for syndromes that develop where the nerves are malfunctioning and the pain's out of proportion to what it should be. But for routine surgery and management, we don't, fortunately, you don't have to see a pain management doctor because the pain is short-lived, hopefully.
Great, thank you. As a follow-up to that, I know we have some questions in the chat, but how long until totally pain-free, say after a surgery, and is there physical therapy after surgery for a while as well?
Yeah, those are good questions. Again, the after surgery, as everybody knows, usually the first few days are the worst. But again, fortunately, with modern the blocks and anesthesia nowadays, the worst pain's blocked for the first day usually, and then after that, people may have a couple days of moderate discomfort, but usually, after the first week, there's not much discomfort for most patients, and some, I think most hardly take any of their pain pills. If they need it, they can, but everyone's a little different. But again, anywhere from, I think, 3 to 7 days of mild to moderate pain at the most. And it's again, it's interesting. Most patients describe the pain as being less than they expected.
Great, thank you. If you have issues with both feet, do you do one foot at a time or you do both?
Yeah, that's a very good question. It's it's hard to do, as you know, to do surgery and have 2 feet that are sore or swollen is not easy. And the I usually recommend against doing surgery on both sides for any procedure that's any for most procedures on the foot. For instance, if it's the surgery is just, say, maybe it's a little a hammer toe on your small toe, or it's a small surgery or neuroma, that's a surgery that's a smaller surgery that's not that significant, less swelling, and you can weight bear easily for initially on both sides. I'll do it so you have one anesthesia. But for a surgery that involves fusing bones or cutting the bone, there's more swelling. Again, you're weight bearing, but I want you to limit your weight bearing for the first couple weeks if possible. Yeah, you can't, you don't want to be in a wheelchair for 2 weeks. So it's really best to do one at a time, because it's just hard having 2 feet that are, a little sore, swollen. Just getting around the house, getting to the bathroom is more difficult. So again, for this procedure, I do not recommend doing both at the same time. And for most significant foot surgeries, but so unless it's a fairly minor surgery, I would caution against doing bilateral foot surgery.
And then how, on physical therapy, how does that play into the role of post-surgical?
Yeah, the therapy we prescribe for some patients, I mean, after surgery, people are, again, they're not in a cast, they're in a boot for this procedure. So immediately you can take your foot out of the boot and move your ankle. You can wiggle the toes. It's okay to keep things moving. Formal physical therapy, not everyone needs or gets, but if after you've been in a boot for 6 or 8 weeks, your ankle gets weaker, and we can give you a list of exercises to do on your own that you can do your own therapy and strengthen your leg. If otherwise, if people want to see a therapist and go through the exercises, they can do that. But the majority of people can gain once they come out of the boot, they can gain the strength and motion of the ankle and the toes on their own.
Great, thank you. Does wearing orthopedic shoe arches help slow the bunion deformity?
Yeah, arch supports it doesn't necessarily slow the deformity. Sometimes as if the joint's unstable, your foot can pronate, or you can develop more and more of a flat foot. But it can occasionally, if you have a bunion, an arch support may make it less symptomatic. It may raise the arch a little bit to rotate the toe a little bit. So it doesn't necessarily reverse the process, but it may make you more comfortable, partly because you're probably stabilizing what is an unstable joint.
Thank you. A question: are hammer toes a result of bunions, or is it a separate condition?
Yeah, that's a good question too. It's the hammer toes. It's kind of both. They are a separate condition where there's a, like I said, there's 28 bones and joints in the foot. There's a lot of tendons in the foot, and the hammer and toes have a subtle balance because you have flexor tendons that flex the toe, that flex the tip of the toe, that flex the middle phalanx of the toe, the middle of the toe, and the same thing, you have tendons that extend both those areas. So it's a kind of a subtle balance. So any type of imbalance in those muscles and tendons can result in hammer toes, where the tip of the toe or the middle of the toe is flexing, bending more than extending, and then that can lead to a hammer toe. So sometimes it's hereditary, sometimes it's from, some neurologic, some people have certain, their congenital conditions where you have a mild neurologic thing where the foot balance, you have the toes are off and you develop claw toes or hammer toes that start rubbing. So sometimes that's a source of it. But bunions can predispose you to hammer toes because as the big toe crosses and starts pushing on the second toe, it pushes it up, and then that causes an imbalance of the tendons. And so the toe can come out of joint, the toe can flex. A bunion can certainly lead to a second hammer toe or dislocated second toe. But hammer toes are kind of are frequently a separate problem. But again, with severe bunions, second hammer toe is frequently associated, and frequently with I didn't mention that before, but if patients that have hammer toes, we do at the same time as a bunion surgery on the same foot. Obviously, we're going to do all the surgery on the same foot is fine, and sometimes people have, I do the bunion correction as I described here with 3 hammer toe corrections because once the toe's straight, you don't want your other 3 toes sticking up and rubbing in your shoes. You want to be more comfortable in shoe wear, and the hammer toes can be corrected at the same time.
And I think you just answered this because the question was really they have a bunion and a hammer toe adjacent on an adjacent toe. Does that make things more difficult for you? I mean, it seems like you're doing it anyway, but is it more difficult?
Well, yeah. Well, I mean, it's another procedure. It's surgery's going to be a little bit longer, but it's not necessarily more difficult, but because we do it all the time. But it's just a slightly longer procedure, but it's the same anesthesia, the same block, the same recovery. Because sometimes correct 2 or 3 of the other hammer toes. Sometimes too, with severe bunions, the second toe actually dislocates, comes out of joint, and then in those cases, people have this, the toe comes out of joint, sometimes it crosses over, and the beauty of this is you can correct that severe deformity, but you also have to get that second toe back into joint by sometimes cutting the metatarsal of the second toe to reduce it, and then correcting the hammer toe. So it's a more complicated, involved surgery, but it's all possible to do at the same sitting.
Yeah. Can a bunion cause a bone spur on top of the foot, i.e. near the ankle?
Well, a bunion, I guess a couple things. A bunion, over time, if the bunion deformity it can sometimes lead to degenerative change to the joint because the joint is not, your joint's made with articular cartilage, so you want the smooth articular cartilage to articulate, and it's specially designed so that the friction is low and it moves smoothly. But once you get a bunion, that joint's off, so it's kind of like it's only half of the joint is rubbing on the smooth cartilage, and it's off center, just like, again, I think a tire that's out of alignment. It's going to wear down abnormally, and you could develop arthritis. And as you develop arthritis in the big toe joint or any joint, with the inflammation, sometimes bone spurs develop. The body reacts by depositing bone in the capsule, or the capsule. Some of the capsular tissues turn into bone, and you develop which are spurs, and so you can develop spurs on the top of the joint, and again, the the big toe joint, the first metatarsal phalangeal joint, is the most common site of arthritis in the foot. But even without bunions, a lot of force goes through that. You may have had an injury playing tennis or at some time because of all the forces. And if the cartilage goes bad in that joint, you can develop spurs over the big toe joint itself. Bunions don't necessarily cause spurs at the level of the ankle, but they, can cause them at the, on top of the joint. And also, as you develop the bunion, the traction of the capsule, you can develop spurs on the inner side. The bump can become accentuated. Again, most of the bumps not because of bone growth, but there can be some spurs on the inner part that we sometimes shave off during this procedure, that are sharp little spurs that have developed at the capsule. So again, spurs can develop with the bunions over time, and especially with severe bunions.
Great. Here's an interesting question. What qualifications should I look for in a doctor to do this procedure? An orthopedic surgeon? She's not from this area, so I'm not sure where she's at, but in general, I guess if someone with bunion surgery, what should they be asking or looking for?
I mean, you can look at the qualifications on their website where they train. As both orthopedic surgeons and podiatrists do bunion surgery. You can look at where they trained, at the kind of volume of surgery they might do. For instance, some of these new bunion procedures, if you can Google them and go on the websites, and there's a lot now of information that you can obviously get online, and some of the, for instance, the company, the Lapidus 3D bunion correction. There are several companies now that have. I mean, there's one that's kind of started that has that really made the device reproducible. There's other companies that have similar devices now, but you can go to those company websites, and sometimes, and they have physician locators. You can get an idea of they frequently show you physicians that have been trained in their procedure. They show you physicians that sometimes they have different categories of, for instance, the volume of the procedures they've done, and if they're teaching the procedure. And for instance, in this case, I've again, as I said, I've really come to appreciate and like this procedure, and I've done one of the highest volumes in the country, and certainly on the West Coast, of this procedure, and teach the procedure. And you can look for kind of those qualifications on the website if you're looking at other physicians, or you can ask them, how many they've done, or what's their experience is with the procedure. And again, you can ask them what procedures they do, because again, some physicians, I feel this procedure is the answer. There's some physicians that still, and there's that are still kind of pushing the minimal incision surgery, which is, I showed you some of those slides, and again, that I've tried that kind of surgery before, and I could do that, but I don't necessarily, the logic, as I described at the talk, doesn't make sense to me. And the point of it doesn't, I think we like doing surgery with smaller incisions and, smaller scars, and that's always a goal. But quite honestly, with this procedure, there's, we have a few small incisions, they're moderate incisions, but they heal well. The scarring, I don't think most patients ever complain about their scars, and some you can hardly even see the scars afterwards. In fact, most, the scars have not been a problem. So I'm not sure the logic of doing the surgery through a small incision, because through a small incision, you just don't see as much. And, the logic sometimes is, well, there's a little less pain or something like that, but maybe not. I don't think there's much less pain with some of those procedures, other slides I showed you, than with this procedure. And again, people that have a severe deformity, they want to correct it right. And so if a slightly smaller incision and a slightly smaller scar, well, doesn't make a big difference. So that doesn't make sense to me. But again, physicians are, there's not, there's more, lots of, like I said, there's 100 different bunion operations. And I think there's some doctors are pushing these other, or not pushing, but are believing or feel that it might be beneficial to do one of these other procedures that requires a smaller incision. And again, immediately it may look good, but I worry about the chance of recurrence. And so that's why I've really come to appreciate this technique and this procedure. So you really have to know what procedure they're doing. And nowadays the good thing is you can talk to their doctor, get the information. There's a lot of information online that you can read about the different types of procedures. And there's there's patient chat rooms even that people talk and to compare their experience. And so there's lots of ways to get information. But this is the but again, I would talk to the physician, see what procedure they do, and see which procedure you're most comfortable with.
And as a follow-up on that, would this procedure specifically be specific to an orthopedic surgeon or also a podiatrist, was the question.
Yeah, this procedure could be done by both orthopedic surgeons and podiatrists.
Okay, great. Thank you, Berkeley. The next question, how long has this procedure been around?
Yeah, yes. Well, like I said, this procedure, the first cuneiform metatarsal arthrodesis, the fusion of this joint have been, again, I think first described by Lapidus in the 1920s. So you could do this kind of procedure for a long time, but it wasn't reproducible. It's much harder to do, and it never caught on until really the last, it's about, I think it's about now 7 years that the reliable equipment and has been out, and devices to make it reproducible and effective as I've described. So it's really less than 10 years that we've been that it's really kind of, I think, come to realize how effective it is. And again, I think the evidence that it is effective is that more and more people have converged to this, and that initially one company came out with this equipment, and it's been copied and reproduced by several other, and the technique has been being done in other ways. So I think it's really been appreciated that the 3D correction, the rotation, is the key to the deformity, and that this is the best way to correct most bunions.
Great, thank you. All right, that was the questions in the chat. Does anyone wish to unmute and ask a live question or add another question to the chat? We still have a couple minutes, almost at the hour. Any final question from anyone? While you're pondering that, I'll also reiterate for the people who came in after I gave the opening statement. This is being recorded. It will be edited over the next week, and then it will be posted not only on the Eisenhower Health website under Desert Orthopedic, it'll also be under our webcasts and those kind of items on the website. It'll also be on our Eisenhower Health YouTube channel. If you've not gone to YouTube, we have our own dedicated channel where we have all of our lectures, past and current, past as in the last probably 24 months, plus all current lectures are up there within at least 10 days after the lecture. If you registered for this lecture online through Eisenhower Health, then I will also, and I have your email, you will get the link from me as soon as it is physically available, and then we'll blast it out to everyone. But with that in mind, we have some thank yous coming into the chat, and hope we have one more question here. We'll end with this. Is your procedure the same as mini incision Lapiplasty?
No. Oh, the procedure is the same as the procedure. Lapiplasty is a brand name for the procedure, but the Lapiplasty procedure is the procedure I'm doing, and it can be done through a smaller incision, and there are guides and devices to do it through a mini, and they're developing even a micro incision with some different plating techniques. So it is essentially the same, and I can do, and I have done the mini incision technique with the same procedure. Yes.
Great, thank you. And I did see Elaine. Did you have a question for the doctor?
Yes, I do. Is your success rate with a severe deformity less than with a moderate or minor deformity? My deformity is severe.
You know, I don't know that I'd say, yeah, I think it's, the success rate I think is almost as high for the severe deformities as for the lesser deformities. Obviously, with the severe deformities, you're correcting much more. There's a lot more going on with the foot. So I think the chance of recurrence is maybe perhaps a little higher, but it's always interesting that when when patients come to the OR, the nurses and the other staff, that they see these severe deformities, and they're always amazed at the end of the procedure how different the foot looks and how much better the foot looks and how much we can correct it. But the severe deformities, you need to make sure for the severe deformities there's not other causes of it, like severe neuropathy or other instabilities leading to it. But the results from the severe, in some ways, sometimes the severe deformity patients are the most satisfied because they had such a deformity and disability for years, and then we really can correct the foot and get it in such a better position. So I think the satisfaction's higher. I think the success rate's very high with the severe deformities.
Thank you.
You're welcome.
All right. Well, thank you, everyone. That is at the hour, and I want to thank everyone for being online with us today and for some great questions. And Dr. Friscia, thank you again for a really wonderful presentation and answering all the questions. That was the perfect kind of end to this lecture for the evening. And any last words from you, sir?
No, thank you for attending, and everyone had great questions. And and again, if you have any other, again, you could go to obviously the YouTube channel or our Desert Orthopedic Center website and Eisenhower website have links that you can look into this more. And if you'd like, to come into the office, you can call through Eisenhower or Desert Orthopedic Center and make an appointment, and we can certainly look at it further or talk about it further. But I appreciate your attention and time, and have a good evening. Thank you.
All right. Well, with that, thank you, everyone. And doctor, thank you so much for your time tonight. I know it was a long day of surgery, so we appreciate you being here.
Thank you.
Thank you, everyone. Have a good evening.